Dr. Mohamed Elfarok. He will talk about arterial closure devices.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation, and I would like to share experience with my arterial closure device. It's usually a problem when you go to the hospital manager, ask him for a new closure device. So I went into this conversation quite a lot over the last 10 years. So let me take you through what I have learned. This is the point I'm going to touch: the future of closure devices and the standard of care and the classification example. And I will just give you probably one video about a recent closure device for venous closure device. We know that we are starting to do a lot of more procedure endovascular, a lot of more PEVAR, TEVAR, and our French curve started to go from 20 to 22, 24 French. So we have a big hole. The growth of the market, if you see the market of endovascular, you can see that everything is growing. Stent market, balloon market, but if you look to VCD, vascular closure devices, their market is growing even bigger, because whatever procedure you will do, you need to close this hole. So definitely it is growing, and by year 2022, it's even, they mentioned it has been doubled, just to check with Abbott criteria. So the first question tell you why not to do manual compression, which is up to 6 or 7 French is fine, or you do it open surgical. So the main thing is to know, are we in the right track or not? So this is very important, because this has been answered in 2014. There is 2 PEVAR trial. I will go quickly through them: the ESAR closure trial and PEVAR trial. It is non-inferiority trial. This is the basic design. Whenever you start something new in non-inferiority study, it mentioned even it's actually better than the old device. So if you go to ESAR, I will go very quickly. They take patient into 2 groups, and there was, at this era, there was the exoseal and femocele and manual compression. So you either use this or that. And you know, now in a lot of center in Europe, they now routinely do exoseal, like Marco Manzi, for example. Manual compression is nearly gone. So they compare, I think, about 1,500 in each arm, and the result came complication rate 6.9 to 7.9. So manual compression complication was actually a lot more, statistically significant. And this is the distribution of clinical complication. You look at the hematoma, which is the hematoma, the big blue. So you get more hematoma with manual compression than using VSD. So this shows that it is better. And their conclusion was frank: VSD are non-inferiority to manual compression. The second trial, which is the PEVAR trial, where they took patient for EVAR, open, and PEVAR, which is percutaneous EVAR, and they distributed them about 150 on each arm. And if you go quickly into the result of this trial, it showed that among trained surgeons, PEVAR is safe and effective. Remember, this is 2014, and it showed that it is non-inferiority. It even showed that it is superior. And in this study, they use ProGlide and ProStar from Abbott. So these are the quick result to comparison of them: statistically significant, less complication. This is the exact conclusion, which is the result of the study. Were striking. There is short procedure time, short time hemostasis, and this is how you can do day case intervention. Now in Center USA, they do day case EVAR. So you come, closure device, you're back home, probably in a hotel near the hospital for a few hours, and you go back home. So we are shifting into this era, and we must use VSD. And this was sustained for 6 months. So VSD is better than open. I will go quickly, because here you have the human brain try to solve the problem of closing a hole. So fantastic idea. So I've collected all the closure devices, and there is video for one of them, but there is no time to show the video. So VSD either active approximator, which have either suture-like techniques, this is designed by surgeon, like a ProStar and ProGlide, actually suture to close the hole, or nitinol clip. And the example for that is a star close. You can have another technique, which is passive approximator. And this you can have a plug, like PGA plug, like the Angioseal and the Vascade. Angioseal up to 6 French and Vascade up to 8 French. Or you can have a gel sealing, and the example for that is Menexa, which is in USA, and Menexa Grip, and you have also Exoseal and Fish. Both of them are gel sealing. The last one is external hemostatic device, and this is by Cardiva, which showed to be extremely interesting new device, and Extra. These are collection of all devices. I've actually collected a video for all of them, but I wouldn't go through the video. This is suture technique. Basically, you get 2 stitches to close it. I have 2 minutes 30 seconds to finish. So these are the videos which tell you how the human brain designs. Sometimes you inflate balloon and they get core. Sometimes you put a PGA plug. Each one of them is really fantastic human thinking brain ideas. So I will go quickly. I wouldn't explain most of them. Some of them are FDA approved and others are non-FDA approved. You must study thoroughly each one of these closure devices in order to be sure. And you must know that you have FDA approved device with CE mark. And you must learn all the tips and tricks. In nearly each VCD device, I usually advise give 2 or 3 courses before you start implementing it. This one work Cardiva like the Amplus plug, and very nice idea, very clever idea. Now, the best in my mind is the venous closure device, which is not found in Egypt, not found in Europe, not found in USA, but it is found in China. So China start to have the first venous closure device. When you put a venous stent and you have a big device, so I was very much interested to know how you can really close the vein, because we are surgeons, we know how friable veins are. So this is Venoc, which is a Chinese company, started to promote the closure device, and this is how it works, because you see the wall of the vein is not like the wall of the artery. So they were very clever. They have nitinol rings, same technique, Sildinger, you put a wire, you secure your place inside, and then you get a nitinol rings, and with this nitinol rings, you get a nitinol loop with memory to close. I will show you how this video happened. This is the nitinol rings, stops at the wall, cannot get out, but it is not tough. It's not like you wouldn't, if you use a ProGlide or Pro Suture, you just destroy the whole damn thing. So it wouldn't work. And it will leave this nitinol with memory ring. And they have tried it. You can see it just closes a vein. And they have tried it quite a lot. So the lessons that I have learned over the 9 seconds that is left is that VSD is here to stay. You must learn it. You must be very competent at it. We all surgeons, we know, like to do a very good usual treating tools very well, because this is our basic structure. And thank you very much. And I would like to invite you all to our first PAVSS meeting in Dubai, 22 to 24, and you're all welcome. And please send us all your lecture and request. And it might change as I've been heard from the boss. Okay, thank you very much.
Thank you, Dr. Omar. Finally, we have Dr. Omar Elfarok. Any questions? I have a question, Omar. Okay, go ahead. Okay, my question is, you showed us these venous closure devices, and my question is, do we really need the venous closure device? I mean, how many times have you had a problem after inserting an IVC filter or doing a venous procedure with a groin hematoma? Usually just a few minutes of compression will do the job.
I totally agree. If you are venous with up to 8 French sheaths, manual compression as good as anything. But once with these procedures that we are now seeing in venous intervention, with the Rotarex device, with the Penumbra, with the Angiojet, with even Angiovac of venous access, we started to see the 20 French. I remember in my era, the first IVC filter I put Greenfield was 22 French, and we used to close the vein. So up to 8 manual compression is good enough. More than this, you need manual compression will not work. It will still bleed. You need either to open closure or closure device. Now we started the era of venous closure devices. I am sure, I know now that Medtronic and Cook are developing venous closure devices, because if you notice the venous intervention curve worldwide is getting double the arterial curve. So they are doing more venous intervention than arterial.
Dr. Assam?
Yeah, thanks, Mohamed, for a great talk. I know you're short of time. I mean, our policy is to go percutaneous for aortic interventions wherever we can. I think it's important that you share with the junior members of the audience when you can't, and what are the contraindications for percutaneous closure. I think otherwise everybody will be trying to do it on everybody.
Yes.
Yeah.
That's a very good point. I have seen a lot of ProGlide and ProStar, which are fixing posterior wall to anterior wall, double lecture, acute ischemia after distal embolization, embolized and fracture closure devices. So I totally agree with your very experienced comment, Assam, that these are tools. Unless you really know meticulously what you are doing and know exact tips and tricks of each one of them, and to do it on a simulator 10 times at least before you do it in human, and avoid any pre-scarring, avoid any kaza, and always get the surgical arm in your pocket once you are in trouble. So this is absolutely perfect comment. I don't want anyone to book a case of PEVAR with a ProGlide and get 2 ProGlide on each femoral axis straight away. No way, it wouldn't work. You're just hitting for a problem. So you know exactly what closure device that you need to use and be trained at it. And I think we all vascular surgeons know how to use tools well. Up to question, Professor Munir?
Yeah, go ahead.
I want to disagree. It's so easy to use. The first year resident do it in our, we don't even cover them. We are sitting in the chair. Don't scare people. It's so easy to use.
With your experience, I would agree. With my experience, I said it needs a lot of experience to get used.
Dr. Samir?
Okay.
Still 1 minute.
I said, we know these devices are expensive.
Yes.
So if you want to just pick up one, put in the shelf, which one you'll pick up?
Absolutely. ProGlide and ProSlide, the Suture one, I totally like them. To put 2 of them if you are crossing 10 French, what at 2 o'clock and one at 10 o'clock. They are the best in my hands. I am experienced in doing them and train people to do them, and they are more secure than other. I think the suturing technique, we are familiar with using suture, and I haven't seen complication rate with them. I agree that they are expensive, but you can see with the PEVAR trial, you get less hematoma, more less hospital stay, more recovery, and this is the benefit. So I totally agree with you. You must select 1 or maximum 2. Be very well trained in them and have a simulator training in them, and then start using in open. And thank you very much that you like my lecture, because your lecture is fantastic, Samir.
Thank you all. We should wrap up. Actually, thanks to all of the presenter, and have a question.
One
I
question
think-
for Dr. Mohamed Elfarok. I like you. I like the Combiclose and ProGlide and ProStar.
Yes.
Do you use 1 or 2 on big holes? Because in the US, because we have a lot of devices, I
use
always
1.
put 2. But I heard that people are getting away with 1 device even for a 14 French.
You can get away if you have a micropuncture set and you go exactly at 12 o'clock and you know you are sure and you know that you don't have a calcification 3 centimeter above or below, because this is change of morphology. In my hand, it's not secure. I do routinely 2 ProGlide, each femoral axis at 2 o'clock and 10 o'clock. In my hands, it is safer. You can get away with 1, but I think you are running too much risk with severely calcified arteries, and if you don't use micropuncture and you have, let us say you went into the lateral wall of the artery, you know that you run into trouble. Thank you very much.
Thank you all.